How's it going, guys? Medium difficulty question, pulmonary, step 1, internal medicine, 2CK, 31-year-old man, today history sharp, left side chest pain, worsens with coughing or deep inspiration. 4 days ago, he recovered from a short illness in which he had coryza and low-grade fever, which just refers to viral infection. Physical exam shows left-sided friction rep. Cardiac exam is normal. He's got a small pleural effusion on the left on chest x-ray. Serum creatine kinase is normal. Question wants to know most likely diagnosis. Just hop through the answers here. Choice A, costochondritis. Wrong fucking answer. This is inflammation of the rib joints. The way this is going to present on USMLE is one of two ways. Number one, they can tell you there's pain with palpation. Okay, so if you have some sort of chest pain and it gets worse when it's palpated, clearly it's not cardiac, clearly it's not GERD/GI related. I see students get tripped up with that sort of thing in a big paragraph, okay? But I'll say, what does it say right there about palpation? I'm like, yep, that means MSK, okay? So that's costochondritis. The other way it's going to present is they can say, there's like chest pain that's worse when the patient reaches behind his or her back or over his or her head. So if it changes with positioning like that, you know it's also MSK. Student says, oh, but can't pericarditis change with position too? Sure, okay. I mean, but that's pain that's worse, central chest pain that's worse when you lean back, better when you lean forward. But pain with palpation, pain that's worse when reaching behind the back over the head, that's costochondritis. It can be idiopathic, just strain. It can be viral related. NSAIDs or acetaminophen can be used to treat. Wrong fucking answer. Choice B, pneumonia, wrong fucking answer. So this will give you, obviously, a long discussion, but if we had a lobar pneumonia, let's say strep pneumo or staph aureus second, they'll just tell you right lower lobe consolidation, dullness percussion. Okay, that's very buzzy. There'll be a fever of some kind. If it's an atypical pneumonia, so mycoplasma, walking pneumonia as an example, interstitial pneumonia. They'll just say bilateral interstitial infiltrates in 9 out of 10 questions, okay? Legionella, chlamydia pneumoniae, viruses in general, bilateral pneumonia. It's a long discussion. Wrong fucking answer. Choice C, pneumothorax, wrong fucking answer. So obviously you would see that on an x-ray, not a pleural effusion, right? So they would tell you that the lung is smaller. You can see the actual loss of lung markings on an x-ray. You need to be able to identify that. So you can Google image pneumothorax. You need to be able to identify that for USMLE. It's not dramatic. They'll tell you there's hyperresonance. Okay, so decreased breath sounds, but hyperresonance and tympanic to percussion. Okay, so that's going to be pneumothorax, ipsilateral tracheal shift for spontaneous pneumothorax. If it's contralateral tracheal shift, that's going to be tension pneumothorax. Low blood pressure plus pneumothorax equals tension pneumothorax, okay? It doesn't have to be due to trauma. Insertion of a needle followed by chest tube, so needle decompression followed by chest tube is what they want for treatment for USMLE. There's one question floating around on NBME. It's rare answer. But there's one question floating around. You need to know that if it's a small, otherwise uneventful pneumothorax that's picked up on an x-ray, patient seems to be perfectly fine, but there's that small pneumothorax there. It can rarely be observed, okay? But needle decompression followed by tube thoracostomy, that is 9 out of 10 times the answer for pneumothorax on USMLE. In this case, wrong fucking answer. Choice D, pulmonary embolism, wrong fucking answer. So they're like giving you risk factors like you're sedentary in a hospital, OCPs, okay, thrombotic disorders, OBGYN, they can tell you a woman had a C-section 2 days ago, and now she got up to go to the bathroom in a hospital, gets acute onset shortness of breath, tachycardia. That's how PE presents, okay? So you have a DVT that's launched off to the lungs. It's dead space, not shunt. So you have a high V on Q. So Q is perfusion, V is ventilation. So Q is low because you have loss of perfusion. So the fraction is high, that's dead space. If it's a low fraction, that's shunt, that refers to everything else. Okay, so pulmonary embolism, heparin is going to be the first thing we do 9 out of 10 times. Okay, there's one question on a 2CK form where TPA, alteplase, clot buster is an answer, but that's only if the patient has a low blood pressure, okay, which is obstructive shock. 9 out of 10 times it's heparin, followed by CT of the chest. Okay, so CT angiography, spiral CT. VQ scan, not the answer unless the patient's pregnant. Okay, it's decreased radiation. Pulmonary embolism, wrong fucking answer. Choice C, actually real quick, I just want to reiterate this. You need to know that on ECG for pulmonary embolism, Patients have sinus tachycardia. The S1Q3T3, fucking nonsense garbage, okay? It's highly specific for PE, doesn't show up in USMLE. They want you to know sinus tachycardia. So they can show ECG shows no abnormalities, but the heart rate's 100. So that's sinus tachycardia. And you need to know patients' pulmonary embolism. 9 out of 10 questions, they're going to have an acute respiratory alkalosis. So CO2 is low, pH is high, bicarb's no change because there's no time for the kidneys to change bicarb. There's one question I've seen where a patient had a low pH in the setting of pulmonary embolism. So they gave CO2 low, they gave pH low. They didn't tell you the bicarb, but the only way that combination is possible is if your bicarb's low, and that's due to lactic acidosis in the setting of obstructive shock. Okay, so if you have shock, you have ischemia to tissues, so you get lactic acid production. It's more 2CK level, but it's fair game for step one. Any type of shock, septic, cardiogenic, hypovolemic, obstructive from PE, you can get lactic acidosis in theory, but 9 out of 10 times, it's just an acute respiratory alkalosis. As I already said, wrong fucking answer. Choice C, viral pleurisy, correct answer. So this is just viral infection causing inflammation of the pleura, the lining cover the lungs. Okay, so I didn't throw it in here as a differential, pleurodynia. Okay, so pleurodynia is when you have viral infection causing inflammation and pain of the intercostal muscles. Okay, intercostal muscle spasm, that's caused by Coxsackie B virus, the same virus that causes dilated cardiomyopathy, and CK will be elevated usually in that question. Pleurodynia, okay, it's different from viral pleurisy. Pleurisy is literally inflammation slash pain of the layer, the lining covering the lungs, okay, the pleural space. So that's viral pleurisy, and its pleuritic pain is known as getting worse with coughing, deep inspiration. It's a sharp pain. There can be a friction rub. This tells you, and if you have a lateralized friction rub, it's not over the center of the chest. You know that that's going to be either a pleural effusion, which we have here. So that could be the friction rub from the pleural effusion. Can be just general inflammation. So this is viral pleurisy. We eliminate to get there because even if you haven't heard of it before, okay, I mean you can clearly eliminate the others to arrive at this answer. And as I said, pleurodynia is different from viral pleurisy. Okay, pleurodynia is MSK, intercostal muscle spasm. You're just going to give NSAID ibuprofen for both viral pleurisy and pleurodynia. And pleurodynia, sometimes your CK can be elevated from intercostal muscle spasm. You know the deal. To make more content, click my Subscribe channel. Appreciate your time. That's it.